All right, guys, so today we're going to go over chapter 33 and 34. So this is where we're going to go into the periodontal decision making, basically how we're going to treat our patient depending on what they present with when we first see them. So we're going to start with chapter 33. So decision making related to periodontal therapy. So our basic concepts in NSPT, that's our non-surgical periodontal therapy, or also referred to as scaling and root planing. So it's the removal and control of oral biofilm through self-care and professional periodontal debridement, supplemented by adjunctive therapy with chemotherapeutics. So that's like Arrestin or a localized antibiotic, or host modulation agents as needed for the treatment of periodontal disease involving natural teeth and implant replacements. So periodontal health is defined as absence of inflammation, so no erythema or edema, no separation or bleeding on probing. Those are how we're going to measure health in relation to perio. So our goals of periodontal therapy are to preserve, maintain, and improve the natural dentition, implants, periodontium, and peri-implant tissues. We want to achieve health, comfort, and aesthetics and function for our patients through this. So NSPT encompasses the plaque removal, plaque control, sub and supragingival scaling, root planing. It's also going to encompass those adjunctive services like we talked about, the chemotherapeutics, and even laser treatment a lot of times too. So oral prophylaxis combines both sub and supragingival scaling of stain and biofilm removal, but the difference there is oral prophylaxis is going to be performed on patients who have absence of signs of disease. So no bleeding on probing, or maybe only localized areas of bleeding on probing, and those pocket depths aren't showing any signs of disease. So maybe we have like a couple of 4 mm pockets, or a 5 that doesn't bleed because it's maybe just the patient has generalized recession, but the papilla are intact. Sometimes you can get some 5 mm pockets there. Tooth positioning, creating a pocket, something like that, where it's not necessarily an active disease site that needs treatment. So periodontal debridement is removal of all subgingival or oral biofilm and its byproducts. And then again, our therapeutic endpoint is we want to see an improvement in gingival health, reduction in pocket depth, and create some kind of a maintenance recall interval. Okay. Okay, so one of the biggest parts when you're doing scaling and root planing or non-surgical periodontal therapy is oral hygiene instruction for self-care. So this is talking to the patient. What are their current tools that they're using at home, and how can you make an improvement for them? Maybe it's someone who doesn't want to floss. So you say, okay, well, they have type 2 and 3 embrasure sizes, so maybe we should just do an interproximal brush instead. Talking about the need for an electric toothbrush, especially if they have exposed root surfaces. I always like to explain to people, I might have said this in class before, but that when you have those exposed root surfaces, we know that those areas are rougher. Under a microscope, they look kind of like fine-grained sandpaper. So cleaning them with a manual toothbrush is really difficult without causing excess trauma to the gingival tissues. So the electric toothbrush is a great tool. Also, the 2-minute timer is a huge help. If you guys haven't signed up for Burst yet, I would definitely recommend it. You can give a link to your patients where they can get an electric toothbrush for $40. The brush heads are a lot cheaper than Oral-B or Sonicare, and they also send you a new brush head every 3 months in the mail. So that's one of the biggest mistakes a lot of patients use with electric toothbrushes is they're not changing the brush heads every 3 months. Typically, Oral-B and Sonicare, the replacement heads are right around like $12 to $15 each, where this one is only like $6 each. I also really like this Pixter's brand of of interproximal brushes because I can give the patient a variety of sizes. So I can give them like a size 0, a size 2, a size 3, and they can try those and see which one fits best. And I always like to give them the instruction of this is something that should fit comfortably and not something that you're forcing. Because if they're forcing it into spaces that the brush is too large for, it will actually can cause some recession or like blunting of their papilla. So it's important that when you give someone an instruction for something that you want them to do, that you also show them it. I don't see a lot of oral hygiene instruction happening in our clinic, something that I think that we could do better of. And the patient really will respond, especially when you're choosing things especially for them. So not saying to every single patient, I want you to use an electric toothbrush and floss. That's not going to be the best thing for every patient. And if you have a patient that's tried an electric toothbrush and they don't like it, then it's not going to be for everyone. Yeah, I wish all my patients used one, but if they hate it, at the end of the day, that's not effective because they're not going to use it. I also like to make sure that if somebody's going to start using an electric toothbrush and they've never used one before, I give them the instruction of use it for 2 weeks, morning and night, without picking up your manual toothbrush in between. Kind of just set your manual toothbrush aside, and then after the 2 weeks, use your manual toothbrush. See if you feel the same level of clean after you're done. Most people are going to, by that point, they're going to be used to the electric toothbrush, like the little things where it tickles their nose or gets toothpaste on the mirror. All that's going to be normal because they haven't used their or their manual in between. So I like to just always give those instructions to people rather than just like, you should be using an electric toothbrush. Talk to them about why in their mouth they should be using an electric toothbrush. Helps to clean better around crown margins, around implants, whatever they have that you can relate is going to make them feel like you're going the extra mile to choose something specifically for them. And that's really important to whether your patient's going to listen to you or not. Okay, so assessment, diagnosis, and care planning. So we know that NSPT is part of phase 1 therapy, okay? So active therapy involves non-surgical care, surgical care, or both. So typically we're always going to start with the phase 1 therapy. And then, because we want to have a healthy foundation before they're doing any kind of restorative care. And then phase 4 encompasses periodontal maintenance. So that's kind of just where we're maintaining. We've gotten all the decay taken care of. We've gotten their gums back to healthy. And so we're just on that like 3-month maintenance schedule at that point. But especially if the patient hasn't been to a dentist in a long time, it's really important to be encouraging to them and to be like, okay, we're going to start with getting the gums back to healthy. We're going to get in there. We're going to clean everything out. You're going to come and see me for a couple of different appointments. I'm going to get you nice and numb so that you're comfortable and that I'm comfortable cleaning in there. And then we're going to get that back to healthy. And then you're going to get to your dentist and you're going to get some of the decay taken care of. And we're just going to take it one step at a time. Something that you want to make, like, you want to make it feasible for the patient, not allowing them to take off too big of a bite at the beginning, but taking it step by step and letting them know that it's feasible to get their mouth back to healthy. Because a lot of people are really embarrassed to go back to the dentist after they haven't been in a long time. And so they're embarrassed about the shape they're in. So it's really a privilege that they're letting you look in their mouths. And it's something that you don't want to be like, oh, this is disgusting. There's so much buildup, blah, blah, blah. No. You want to approach it as this is something that's manageable, like we're going to get you back on track. And I'm going to help you do that. And answering their questions and their concerns, trying to figure out why they fell off of a recare in the beginning. Maybe they had a bad experience. That's usually what it is. Or they lost insurance, something like that. It's not just they decided not to take care of themselves anymore. So kind of finding that out and trying to avoid that happening again. So also, we know that periodontal disease, like we talked in perio class, has times of inactivity and times of exacerbation. So when we see someone can have periodontal disease but not have active inflammation signs, so they can be healthy on a reduced periodontium. We talked about that a lot in perio, but those people are still going to be periodontal maintenance patients. And I have a chart at the end of this lecture that I'm going to spend a lot of time on, kind of going over our decision making of how we decide what a patient needs. Do they need a prophy? Do they need localized SRP? How do I decide their recare? All of those things. And this is kind of a gray area, guys. Me and you might have different ideas, and they can both be right. So it's just kind of trying to figure out what's going to be the best for each patient and going through this decision making every single time we see somebody. So periodontal maintenance, usually it's abbreviated with PM or PMT. This is going to be an extension of our periodontal therapy. So basically this is going to be at the end of after we've root planed someone, or if they've had like surgical treatment in the past, any kind of gum treatment in the past, this person should continue to be a periodontal maintenance. Now, when you get in private practice, a lot of times people will, what they'll do is insurance typically allows for 2 prophies and 2 periodontal maintenances every year. So they'll alternate a periodontal maintenance and a prophy. Now, if I'm being honest with you, this is what I do in private practice. I'm okay with that because this helps me every 6 months. I have to do a perio chart because every single time you do a periodontal maintenance, you should do a perio chart, like full perio chart, record it. And that's what insurance is going to want when you do a periodontal maintenance. The part that gets confusing is a periodontal maintenance is a lot more expensive, like almost double the cost of a prophy. So a prophy, typically the patient is not going to have a copay, where a periodontal maintenance, the patient is going to have a copay. So they're going to be like, what's the difference? You do the same thing every time. So when I get done root planing someone, usually what I'll say, okay, now I want to see you on a more regular recare. Whether that's 3 months or 4 months, I determine and talk to them about it. Now, what I also like to explain is I'm going to clean your teeth the same way every time. I'm going to bill it different to insurance so that you can maximize the benefits. So a couple times a year, I'm going to give you a deal, but I'm always going to be doing this periodontal maintenance, or gum cleaning is how I explain it to them a lot. That way, when they get to the front desk, they understand, okay, I'm coming 4 times a year. This is how they're maximizing my insurance benefits. And some offices just do 4 PMTs a year. I like to, though, like, I would rather have my patient come 4 times a year and 2 times not have a copay, and that makes them more apt to come see me and maintain their health, than have a periodontal maintenance every single time. That's my personal opinion. Doesn't mean that if an office does it differently that they're wrong. Some offices do 4 prophies a year. I don't love that because, again, you're not maximizing their benefits. 2, you're getting gypped out of this periodontal maintenance because you're doing this extra work, that you're cleaning the root surfaces, you're cleaning the furcations. That's why they made this code, is because as a hygienist, you're doing a lot more work when you're performing a periodontal maintenance. Now, the patient, though, feels, hey, you're doing the same thing as always, so why do I have to pay more for this one? So it's just basically, it's explaining to the patient from the very beginning, this is what we're going to do. I'm always going to be doing the gum cleaning for you. It's just a couple times a year I'm going to give you a break. So even when our patients are in a refractory period where they're not showing signs of inflammation, they still have periodontal disease. We're still going to do a periodontal maintenance, okay? Once they've had perio treatment, they don't go back to a prophy, okay? So in our clinic, the standard is going to be, if a patient has ever had any kind of perio treatment, if they have a reduced periodontium, they have periodontal disease, and they don't need active treatment, like they don't need any areas of root planing, they have every area is healthy, we're going to code them as a periodontal maintenance, okay? 4910, D4910, periodontal maintenance, okay? Every single time. Okay. So, usually periodontal disease, like we've talked about in class a lot, is something that progresses slowly and will respond in a relatively predictably manner to non-surgical periodontal therapy. The main focus of NSPT is oral self-care education, because at the end of the day, a patient sees you max 4 times a year. What they do every single day at home is so, so important. And it's really important to hit home with that. And I always end my root planing sessions with, okay, they know I worked hard because they felt me scraping for days and sweating and whatever. So at the end, I'm always like, okay, I worked really hard to do my part today. So what I need from you is to keep these areas really, really clean so that the gums can heal. Because if they go home and don't do good oral self-care after you root plane, then it wasn't worth doing it. Like it just, the gums aren't going to be able to heal, and we're never going to be able, we're going to just always be backpedaling on those patients. So making sure that when they leave, hey, we've spent all this time, all this work in those areas. So now I need you to do your part, and also making sure, like we talked about before, that they have the proper tools to be able to do their part. That is so, so important. I'm not going to give a dude with huge hands with arthritis a string floss and say, you need to string floss every day. No, I'm going to find something that he feels like he can use, talk to him about it, and then discuss from there what we're going to choose for him to be his interproximal cleaning aid, okay? Because the most important part, like I said, is that the patient's going to use it. Okay. So also, periodontal surgery may be indicated for advanced periodontal sites. So this is what I've been talking about. I know a lot of you, we've already discussed referrals to a periodontist with some of your patients. Now, those are people that I feel like the sites are probably going to need surgery at some point. And truly, I don't like to get into those sites because when we get up into those 7, 8, 9 millimeter pockets, even like a 5 and a furcation, I'm like, I'm not going to be able to do my very best work in there. They're going to come back and either I've created a perio abscess or I made the pocket deeper. So those areas, it's being able to recognize those, and we're going to help you guys do that. But even when you get into private practice too, like not being like, I'm a superhero, and always giving the patient the option to go to the periodontist, I think is the very best thing. And at the end of the day, that's treating every patient like they're your mom, your dad, your grandma, and you would want them to have the very best care. If my mom had an 8 millimeter pocket, you are very sure that I am not going to dig around in there. I am going to send her straight to the periodontist, okay? Because I know that that's how she's going to get the best results. Okay, so we have our grades of periodontitis. We have talked about this a ton. Our grade A, B, and C. We're getting a lot better at recognizing this, and we're going to keep practicing. This is going to be something that as you guys see more advanced patients, you're going to get a lot better with understanding the grades. Okay, so care planning considerations. So we want to talk about our medical history, right? Because is there a systemic disease present? If there is, that person needs to be coming every 3 months. If they're diabetic, guess what? Insurance has recognized those patients are at such a high risk for perio. They will cover a 3-month periodontal maintenance without ever even doing any scaling and root planing. Normally, insurance will not cover for periodontal maintenance unless they've had active perio treatment in the last 18 months. Now, in our clinic, since we're not billing insurance, we have the freedom that we can kind of charge for a periodontal maintenance when we're doing one, because we're just learning, we're just practicing our coding. But those systemic diseases, it's important to be able to know, A, for how you're treating someone. We know that those people are going to have poor wound healing. We know that they're going to probably have a lot more bleeding. So it's just understanding their medical history when you're doing your care planning decision-making process. Some people, we may need to do a consultation with a physician to coordinate medical and periodontal care. So especially if there's someone who's undergoing chemotherapy or they're about to, just kind of taking which one is going to be priority at that time. Obviously, that person is in a life-threatening situation where the chemo is number one. Maybe we give them some good oral self-care aids to use while they're in chemo. Then once they're finished and doing better, then we address the periodontal care. We want to talk about risk factors. Do they have a strong familial history of periodontitis? We want to talk about any antimicrobial chemotherapeutic therapy, so including systemic antibiotics. So if somebody has areas of maybe grade C periodontitis and they're young, we might want to do some systemic antibiotics, something that you're talking to your doctor about. At that point, personally, I'm referring to the periodontist. I don't do systemic antibiotics in our office. We just refer those patients out. Adjunctive host modulation. So also using microbiologic identification. So what kind of bacteria are we dealing with? How deep are the pockets? Are we having like mostly gram-negative anaerobes? How can we kill those bacteria? Like using a laser. And we're going to talk about the laser a little bit later. Those are going to be your more advanced perio patients that you see like in the fall and spring of next year. Mostly probably spring where you're using the laser. But we'll get into that in perio next year. And then also always taking into consideration any allergies, antibiotic sensitivity testing. And then, like we talked about too, genetic susceptibility. So if they have a strong familial history, like both their parents have dentures and so does one of their brothers or sisters, that's like, okay, so we're seeing a strong genetic susceptibility there. Okay, appointment planning, and you guys are getting a lot of good practice at this because our patients have to come back for a lot of different appointments. Typically in private practice, the length of the appointment is going to range from about 40 to 90 minutes, depending on the patient needs. So if I'm going to like use the laser, I know that that takes me an extra 15 minutes because I got to set it up, I got to put it away. So just depending on that, I plan for my time. Some offices are going to have a set time for scaling and root planing, but ultimately, just be in good communication with your doctor and let them know how much time you need. Use of pain control or anxiety management strategies are really important. So talking to your patient if they have, and like being able to read if they have any anxieties. But if your patient is someone who's taking anti-anxiety medication before regular cleaning, they're definitely going to need it before NSPT. They're also every single time going to need to be numb. Okay. Most people, their number one fear at the dentist is pain. Couple people fear needles. Okay. But you can talk people through that. We use the smallest needle in medicine. You guys are going to be just experts at giving local anesthesia. Hygienists are always a lot more careful. It's just who we are in our nature. But you guys, the number one mistake that I see, especially in students, is not using local anesthesia for scaling and root planing. Patient isn't comfortable and they're not going deep enough and they miss a lot of calc. Okay. And I even see that in private practice. Use anesthesia for your scaling and root planing. Okay. Every single time. I don't give patients the option. Now, I do have some patients that are like, I don't want to be numb, and they don't even get numb for crown preps. And I'm like, okay, great. Because those people, that's a different story. But those are going to be your exceptions. For the most part, you're going to want to use anesthesia on every single patient, okay? Typically, we're going to be, for those 40 to 90 minutes, it's going to be half the mouth, right? Because again, we're using local anesthesia, and it's not comfortable to do the whole mouth in one visit. Also, if you're doing the whole mouth in one 40 to 90 minute visit, you're not doing scaling and root planing, okay? Because at that point, you don't have enough time to scale and root plane every surface in 40 to 90 minutes. So also insurance doesn't allow that because again, they recognize that if you're doing it in 40 to 90 minutes, it should probably be like scaling in the presence of moderate to severe inflammation, the D4346 code, or something else. But in general, NSPT takes more time than oral prophylaxis or periodontal maintenance, okay? Most important factor in determining success of periodontal therapy is going to be the thoroughness of root surface debridement. Did you remove all the biofilm? Okay, so if you don't remove the plaque off of the surface of the calc, you're done. If you don't remove all the calc, then the calc or the biofilm is just going to reaccumulate. We know that calculus itself is not harmful. It's the fact that it's always covered in biofilm and that bacteria just can live in there forever. That's what causes a problem. That's what the bone and the tissue don't like, is the bacteria. So how well did we clean? Did we get all the calc off? And what's the patient's oral hygiene going to look like when they leave? So those are the two most important things. Okay, case presentation and informed consent. This is huge. Letting the patient understand that there are risks when we do non-surgical periodontal therapy. They can have increased sensitivity. When you remove all that calc, we might get some recession, which is what we want. They're going to need to come more often for long-term success, like every 3 to 4 months, like we know. And periodontal debridement is an extensive procedure. Like, there's going to be a lot of pressure and a lot of noises, takes a little longer. And then also letting them know from the get-go, this might take 4 appointments, this might take 5 2-hour appointments, just depending on what they need. But I always like to encourage patients, okay, it's going to take us these 2 90-minute appointments, and then from there, every cleaning is going to be a lot easier, and we're going to get you back on track. This is going to be kind of like a Control-Alt-Delete for your gums, so that we can get you back to a healthy state. So that it's also important to explain to the patient, when they have these 5 and 6 millimeter pockets, they can't clean those every day at home. So we want to get the areas to 2s and 3s, so that they can clean them with their toothbrush and floss. And once you explain that to the patient, they understand, like, oh, okay, and that's also why I need to come more often, because typically it's going to take 1.5 years or 2 years before we get all those sites back to healthy. Also, we want to talk to the patient about a possible reevaluation after the initial scaling and root planing. So typically what I like to do in private practice, I do one side of the mouth, I wait 4 to 6 weeks before I do the other side, and then I can check how the first side is healing. You guys in clinic, I want you to do, once you finish your scaling and root planing on that patient, you're going to schedule your final appointment for 6 weeks from there and do a reevaluation. At the reevaluation appointment, you're going to do a plaque debridement, and you're going to reprobe and see, okay, do we have any areas that we missed that still have 6 millimeter pockets or greater? Do we need a perio referral? Do we need to use some Arrestin or a laser? The reevaluation appointment, guys, especially while you're learning, is so important. Sorry, my computer is like giving me all these alerts. But so important. Did we do a good job with our scaling and root planing? Also, like we talked about a couple weeks ago in our clinic huddle, utilizing those post-scaling x-rays. If you have a really difficult case, let's take some post-scaling x-rays. It's a really low risk for us to be able to see, did we get to the base of that pocket? Because sometimes it's so hard and there's really difficult areas. Yeah, and also I like to always let my patients know the need for pain control. So I'm going to get those areas nice and numb, and I like to explain to them, this is for you to be comfortable and for me to be comfortable. Because if I know if my patient's uncomfortable and hurting, I'm not going to be able to do a good job. And I like to explain to them that you know, digging underneath those surfaces over and over again in order to get them nice and smooth and clean is uncomfortable, and I don't want you to be uncomfortable, because then I can't do my job as well as I want to. And once you explain that to people, most people are going to be really receptive, okay? Alrighty, so our implementation phase of NSPT. So this is going to be, like we talked about, so important, that self-care education. We're going to be doing our manual and mechanical instrumentation, so using our hand-activated and power-driven devices. We're going to use chemotherapeutic interventions, like we said, Arrestin. Pain control strategies, we're going to use local anesthetic every single time. And we're going to do stain removal as needed, okay? So like if we have an advanced case and we decide we're going to use Paradex, I'm going to let my patient know that I only like to use Paradex for like short periods of time. So they come for their initial appointment. I do a full mouth debridement, have them start using Paradex. And then I'll warn them it's going to cause some stain. When you come back for your deep cleaning, I'm going to take it off. So then give them the Paradex, let them use it for 4 weeks, do their scaling and root planing, and then remove all the stain, and then have them stop using it after a couple weeks after they're finished with scaling and root planing. For you guys, since you have that reevaluation, you can have them continue using the Paradex until the reevaluation phase, because then you're going to remove all that stain too. I just don't like to let the patient go 3 months with all this stain on their teeth, okay? Alrighty. Supportive intervention. So overhang removal, desensitization, dietary assessment and counseling, especially if there's someone who's getting like root caries. Smoking cessation, huge that they understand the risks with smoking and periodontal disease. Dental caries, risk assessment and risk management. Do they need fluoride varnish? Do they need to be using a fluoride rinse? Prescription fluoride toothpaste, what do they need? And this is just complete care, okay? This is making sure that we're doing our very best for the patient. We talked about this. Full mouth disinfection, that's like using Paradex or something as a rinse while you're scaling and root planing. This is something that like doesn't have a lot of research. A lot of hygienists like to do this. A lot of hygienists like to put Paradex in their Cavitron units if it has a standalone water source. Like I said, hasn't been research supported, but some people love it. So, okay, so the basis of successful NSPT is thoroughness of periodontal debridement, like we said, getting everything off. So we want to select our instrument for each patient. We're not going to always use a 13-14 and an 11-12 for every root planing case. Do we have really narrow pockets where we're going to use our minis, which we just got those for you guys. So we'll be showing you how to use those really soon. But what type of depositor? Is it really tenacious? Do we need the really heavy ultrasonic tips? What is our pocket depth? Do we need a really thin one for those deep furcation areas? What kind of inflammation are we dealing with? Is the tissue really tight, or is it really wide open and inflamed? What's our bleeding looking like? What's our access? Do they have a small mouth? Do they have trouble staying open? Do we need to use a bite block? Remembering our root morphology, and knowing the pocket shapes. So sometimes you're going to have really narrow pockets where you're going to need really thin instruments. Other times you're going to need a 15, 16, 17, 18 because maybe they have their third molars, or if they have trouble opening, that way the instrument's a little bit more adapted. They don't have to be open as wide. So guys, it's really important. Do they have mobility? Assessing all that stuff. That's why we do the perio chart. We write so many notes so that when they come back for NSPT, we have a plan. We know what kind of instruments we're going to need. We write those notes like patient needs a lot of breaks, patient needs a bite block. Should you use a bite block on every patient because you like it? No, because not every patient's going to like it. We want to make sure, first things first, our patient is comfortable. We are comfortable. Using your patient still, turn towards me, put your chin up, making sure that we're talking to them in a kind way, even when we're struggling. We don't want the patient to know like, oh my gosh, this is so hard. We want them to think, that we're killing it when we're in there, even if it's a difficult area. And I'll let my patient know when it's difficult. If I'm working on a mobile tooth with an 8mm pocket, they know that I'm struggling. And at the end, I like to let them know like, hey, I did my best in there today. But ultimately, long-term prognosis of that tooth is not good. Because it's also important that we don't give them false hope. And again, referral to the periodontist. Some people are going to deny it, and that's fine. But as long as they've had the option, okay? Clinical outcomes of periodontal debridement. So, most important thing, like I said, we're eliminating that bacteria. So we want to change the microbial colonization. So cleaning subgingivally, sub and supra even doesn't remove bacteria from the tongue or tonsillar areas, which can be a source for reemerging periodontal bacteria. So showing patients how to clean their tongue, and you can tell when it's time for someone to clean their tongue because their papilla get elongated and stained, or you can smell it. Microbial repopulation of subgingival pockets can be slowed or inhibited. Again, patient home care is so important in that. Shifts in health are subgingivally are transient. Hand-activated, ultrasonic, and sonic instrumentation all produce similar clinical microbial results. Minimal or no bone repair occurs after scaling and root planing, so the bone doesn't regrow. With laser treatment, they're kind of disproving that you can actually stimulate the osteo regeneration process. So, and we'll talk about that when we talk about lasers, but we do want to make sure that the patient understands when we have bone loss, we can always get more, but we can't regrow the bone, okay? And as always, this is so huge. Incomplete instrumentation and or growth of supraoral biofilm contribute to the repopulation of microbes in pockets, okay? So stressing that to the patient. Clinical endpoints measure the surface's preparation for healing of adjacent tissues. And then we're constantly evaluating these, guys. So that's why we're having people come every 3 months. We're always measuring their pocket depths, measuring for bleeding. What does the tissue look like? How is it changing? Referral to a periodontist. We've talked about this a lot. Type and severity of disease, dental hygienist's acquired experiences. So taking that into account is super important. And then time allotted to maintain periodontally involved cases. So if you're at an office where you have an hour to do 2 quads of SRP, those really difficult cases, you better be referring to the periodontist, okay? So this is a picture of flap surgery. And I don't love this picture, but they left the papilla, which that doesn't usually happen. Usually they remove all those because ultimately we do want to encourage some recession. This looks like more of an area where they just wanted to they had like some dehiscence up here from toothbrush abrasion where the tooth is showing up here and then we have like a layer of bone. But this is what it looks like when somebody's flapped up. So you can see how like if there's subgingival calculus right here, you can just jump at it because you can see it. And again, I really want you guys to be able to experience this. So I'm still looking for a periodontist to come to the clinic to do this for us on a couple of our really advanced patients. And then surgical intervention. So are therapeutic goals being achieved? Let's say we've been seeing the patient for a year after SRP. We're still getting a lot of bleeding. We take x-rays again and there's more subgingival calculus accumulation and we're just not being able to keep up. That's when we're like, okay, this patient needs some perio surgery, okay? And then osseous defects too, like those vertical bone defects, we're never going to be able to heal those with just scaling and root planing. So it's super important, those patients, to recognize that and refer to the periodontist, okay? So like we talked about, using the laser, antimicrobial agents, or antibiotics. So we talked about the dental benefits plan. It's really important to understand insurance stuff, and we're going to go over that more and more as we get you guys closer to graduation. Like your final semester, your clinic class is basically going to be like real life dentistry, and we're going to talk a lot about like actually when you're in private practice, how it's going to work, understanding some insurance stuff, how to code, understanding insurance plans. That way you guys can understand, because that's something that I wish I knew a lot more about before I came out. I didn't even know what like a prophy was coded. I didn't know it was coded as 1110, okay? So I want you guys to be able to understand insurance stuff For right now, I'm not super concerned. I just want you guys to be practicing the proper coding, okay? So if we're doing active scaling and route planning, coding it as the 4341 or 4342. If we're just going to do periodontal maintenance, doing the 4910, recognizing those, and then doing the proper recalls after, okay? But it is important that you do understand that, especially if you're working in an office that accepts insurance. Okay. Talked about periodontal maintenance a lot already. And you can have someone who's on a periodontal maintenance interval only coming twice a year, okay? We customize this to the patient needs, always, 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 okay? Any active sites of periodontitis, though, any like recurring sites, that patient needs to be on a 3-month recare. Treat the area and be on a 3-month recare. And then again, appointment time. My periodontal maintenances are the same time as a pro fee. I just don't have x-rays or an exam when I do a periodontal maintenance, okay? Understanding compliance. We've kind of already talked about this a lot too, talking about risk factors, keeping our recommendations simple yet thorough. We don't want to introduce 5 different tools in one appointment. We want to make it something that seems feasible for the patient to do. And then pay attention to your patient's questions and needs, okay? We want to talk about disease processes, all those things, but not overwhelming them. This is something that I'm going to print out for all of you guys to keep in your operatories. So I want to go over this one quite a bit here. I want you guys not to worry about the case types on here. The case types are a little bit different than ours, but I really liked this chart for the data on the far left side, deciding what we're going to do. Okay, so a patient comes to the office, they have huge, heavy deposits. We talked about this a little bit too. We can't even see anything because it's covered in supragingival calc and stain. We're going to do a full mouth debridement. That's where we go through and we just try to get all the supra off so that we can see what's going on and that we can probe, okay? Basically, if you can't even put a probe in because there's so much junk, full mouth debridement. Doctor can't do an exam, full mouth debridement, okay? Then we're going to have them come back in like a month, reevaluate the tissues, and then that's where we decide, okay, is this patient just going to be a prophy? They just had like a bunch of supra. Or are we going to go into at least some localized SRP or full mouth SRP? Is it going to be a referral to the periodontist? So, and then doctor can do his exam. In the state of Hawaii, hygienists cannot diagnose scaling and root planing. So this is something that technically your doctor will need to diagnose at the comp evaluation. So, and that's just going to depend on what practice you work on. We're going to talk about that more. Typically, like my doctor gives me like full reign over perio stuff. Okay. Like if I think a patient needs SRP, he will come in and back me up every single time. So it's important that you're on the same page with your doctor there. But technically we cannot diagnose. So we need to have the doctor come in, even if they're not scheduled for an exam that day. Maybe it's just your recall patient, they're coming for a periodontal maintenance. You're like, hey, no, we need to go back into active therapy. I'm going to do 2 areas of localized SRP. I need to have doctor come in and evaluate those areas too. Okay, so let's say in the next one, our green boxes, patient comes in, they don't have any subgingival deposits, no bleeding on probing, pockets are 1 to 3. We're going to go prophy, D1110, okay? Recare interval every 6 months. Also, there's recommended home care, okay? Now, let's say it's been a little over 6 months since the person's last visits. We've got some 3 to 4 millimeter pockets, no attachment loss, no bone loss, okay? What are we going for? We are going to do, we could do a full mouth debridement plus a prophy if they have a little bit more build up. We could do a prophy 1, prophy 2, okay? So typically, if it's been a couple years since your last cleaning, then insurance will allow you, like HDS, which is probably the most popular insurance in Hawaii, Delta Dental will allow you to do 3 prophies that year if it's been more than 2 years since their last prophy. So you could do a prophy 1 on July 1st and then have them come back in a month and do prophy 2. You could do a full mouth debridement and then a prophy 1. And then, or you could do a D4346, scaling in the presence of moderate to severe inflammation, and then a prophy. So see how there's so many options that you could do, but it really just depends on what the patient needs, okay? It depends on how much time you need, and it just, like I said, depends on the individual needs of that patient. This one says 2 sessions, 14 days apart. That's great too, okay? And then recare schedule, maybe the first time we have them come back like in 4 months. So let's say we do a prophy 1, 2 weeks later we do a prophy 2, then we have them come back in 4 months. Things look totally healthy. Their home care's improved. They got the electric toothbrush. They started flossing a couple times a week. Okay, great. Let's do a 6-month recare, okay? Let's say they come back, they're a mess again, and they've got a couple areas where now we have 5 millimeter pockets. Okay, maybe it's time to do some localized SRP on those areas, okay? Now our red boxes, this is going to be pocket measurements of 5+. We have bleeding on probing, maybe some recession. We have tartar and plaque below the gums, furcation and or mobility. We're either going to do some localized periodontite treatment, like D4342, which is 1 to 3 teeth per quadrant, or we're going to be doing 4 or more teeth, okay? This depends on A, how many teeth do they have in their mouth that are affected sites with pockets of 4 or more. And then it's also going to depend on just how many sites are affected, okay? So, a couple other codes here. Are these people going to need fluoride varnish? Probably. Are they going to need laser therapy? Maybe. But also we can start using these codes for like localized delivery of antimicrobial agents, D4381. Important to just start getting in the habits of using these codes. Some of them are non-reimbursable by insurance, but it's still good to let the insurance know what we're doing, okay? And then after that, we're going to do a periodontal maintenance every 3 months for 2 years, okay? I'm like pretty strict about that with my perio patients. Like if I do scaling and root planing, I want to see them every 3 months for 2 years. After that, okay, we can go to 4 months if things are looking good. But for the most part, I keep those people on a 3-month recare because they almost always have sites that go back into active, okay? Okay, and then our orange boxes, patient previously treated for perio, they're going to go to periodontal maintenance every time, even if everything's really healthy. So every time I have a new patient, I'm always asking them, have you ever had gum treatment before? Any kind of a deeper cleaning, any kind of a gum surgery? It's important to know that, right? Because it's going to help us to establish a recall interval, and it's also going to help us establish how we're going to treat that patient, okay? Because if a patient has had perio treatment in the past and they have a bleeding 5, I'm going to root plane it. Now, if a patient's never had perio treatment, I might treat the bleeding 5 a little bit different. It just depends, okay? And you guys are going to get better with recognizing this. It's just something that I want you to start, you know, when you're doing your perio chart, looking at your x-rays, all those things, starting to go through this decision-making process in your mind, okay? Okay, we're going to head on to chapter 34, which is acute gingival and periodontal conditions. And we've printed this is like all review from perio, so I'm going to kind of fly through this one. Periodontal abscesses. So these are distinguished by location and course of disease. So it's different than like a periapical abscess, okay? So you can have single abscess or multiple abscesses. Usually the multiple abscesses are going to be a systemic factor that's going on. Their immune system can't fight. All periodontal abscesses have a similar pathogenic microflora. It's comparable, the microbiology is comparable to periodontal diseases. So we're having a lot of those gram-negative anaerobes, spirochetes. Acute periodontal abscesses are usually going to be a localized accumulation of pus in the gingival wall of a periodontal pocket. It's associated with pre-existing periodontal disease, pocket depths of 5 millimeters or more, furcation involvement, tortuous pocket anatomy, so like those really thin pockets, foreign body lodged in the pocket, so like if food gets caught, popcorn husks are a really common one. Also, incomplete scaling and root planing. If you scale and root plane and the tissue tries to heal over a piece of calculus, you'll get a periodontal abscess. So if your patient calls a couple weeks after you did SRP and they said, I have a bump on my gums, you made a periodontal abscess. And it's going to happen to everyone. I just had a patient that called a couple weeks ago that had this happen. But I was scaling in a 9 millimeter pocket on a maxillary first premolar, and I could like scale in the furcation of a maxillary first premolar. So I was like, this ain't good. It was like class 2 mobility. And I warned him at the end, I'm like, this tooth probably isn't going to last long. So one of those things, it happens. It can be associated with any tooth. It's usually going to drain through a fistula or directly through the pocket opening. Let's see. So typically, you'll just get in there and clean the abscess out. So you can actually go through the fistula, and then because the fistula has an opening, so you can put your Cavitron tip just directly in the fistula and then directly in from the pocket too. Okay. Oops. There's a picture here. Okay. So a gingival abscess is going to be this one here. Okay. Periapical is going to be a little bit lower down. Okay. And you'll be able to tell by like a PA. Because a periapical abscess, it will be like right around the tip of the root, and a periodontal abscess will be more towards the side. Okay. Like I said, again, dentist or periodontist removes the foreign object. Patient is rescheduled for observation 24 hours after initial treatment. Periapical abscess, these are the endodontic abscesses. Most common in a dental emergency. These ones usually hurt really bad. Unless it does have a fistula, if it has a fistula like this, typically it doesn't hurt because there's not pressure being built up in there. It's able to drain itself, so those ones typically aren't causing pain. Okay. Great. Periapical abscesses are typically going to be a root canal. And you can have a perioendo abscess. And this is something that just usually will happen like in furcations, but it can originate in periodontal tissue and can progress to the pulp through the openings at the apex or lateral canals. Okay. And usually you'll have to have endo created on those. Okay. Because the periodontium is continuous. Herpetic infections, again, we've talked about primary herpes quite a bit. Typically, it's going to happen in children that we have that primary herpetic gingivostomatitis. Really painful lesions all over the mouth. Most important things to know with this, primary herpetic infections happen in young children typically, and we don't want to see people when they have an active herpetic lesion, okay? So when they're in the vesicular stage, they're contagious. So we can spread it from site to site, okay? Again, professional care should not be performed. Sometimes people will call and be like, oh, I have a cold sore, I can't come in. Canker sore is different than a cold sore. So an aphthous ulcer on the inside, not contagious. Herpetic lesion on the outside that's in the vesicular stage, contagious, okay? Okay. We've talked about herpetic lesions quite a bit, okay? Pericoronitis. This is, just like it sounds, inflammation around the crown, okay? So soft tissue inflammation associated with a partially erupted tooth. You see this a lot on third molars or partially erupted first or second molars when they're coming out, An operculum is a tissue flap that either completely or partially covers the associated tooth. If this happens on a third molar and it's an area that just like commonly gets inflamed, I'll give the patient a monoject syringe so that they can just shoot it back there and clean it out. Typically something's stuck, like food gets stuck, a seed of some kind gets stuck back there, and that's what causes the inflammation. Typically it's really painful, red, swelling. They can get a foul taste. You can get swelling of the cheek. And again, usually if it happens once, it continues to happen. And that's like when it happens on third molars that we recommend them being extracted. Usually it's lower third molars that you see them more commonly. But we want to clean it out. Topical anesthetic or anesthetic is usually applied first because it's painful. But a lot of times you can even just like blow air back there and you can see whatever's in there. Like the tissue will just flap back and you'll find like a popcorn kernel or a seed or something, okay? Sometimes it will need antibiotics. If the whatever got lodged in there got lodged really deep, and that's typically tooth needs to come out, they need systemic antibiotics. NUP and NUG, we've talked about a ton. Gray pseudomembranous membrane, pain, horrible odor, fever. Okay, so that is it. Don't forget to do your post-lecture quiz, okay? And like I said, I'm going to print out that chart for you guys to keep in your ops. And if you have any questions, feel free to shoot me an email. Thank you.